I welcome you all for Dr.Nimisha's Ph.D. Viva Voce. Sir, I welcome Dr. Thaimoogambigai sir, the senior most person. He was also there when I was teaching. Interesting topic. She is talking about the nexus between periodontal disease and the respiratory disease. She has taken two different topics. Like she is talking about, I think we are all aware about the pandemic, what we went through. And she is discussing about the pandemic and periodontal disease and the most common respiratory disease, COPD, and the link between that and periodontal disease. And to talk about Nimisha, she is my PG student as well. And she's showing the same sincerity like how she was there before. The same sincere effort she had put in for the last 4 years, and I'm very, very proud to have her as my student, and she's one of the role model students, we can say. And the forum is to you, Nimisha.
So good morning all. Today I'm here to present my research on exploring the nexus between periodontitis and respiratory disease, a comparative evaluation of galectin-3 level in coronavirus disease 2019 patient and role of NETOSIS and microbial dysbiosis in chronic obstructive pulmonary disease patients with and without periodontitis. So these are the contents of my research work which I will be detailing further. So oral and systemic health are deeply interconnected, each shaping the other's balance. So the mouth often mirrors early signs of systemic disturbances. Recognizing this link strengthens diagnosis, prevention and comprehensive patient care. So is periodontal disease a risk factor for systemic condition? So what is chronic periodontitis? It's an infectious inflammatory disease which is caused by the bacteria of the plaque, resulting in the progressive destruction of the tissue. So recently there has been a resurgence of interest between the periodontal disease and respiratory disease. Why? Because there is an anatomical continuity between oral cavity and lungs, making oral cavity a reservoir for the colonization of respiratory pathogens. So coming to global disease burden, India accounts for around 32% of global burden of respiratory disease, out of which chronic obstructive pulmonary disease has got 384 million cases per year, and around 3 million people die every year, and it is considered as a third leading cause of death. And data shows that by 2050, around 592 million people will suffer from this. So even though initial pandemic has passed away, we are still living in the era of COVID-19, where new variants emerge daily, which lead to long-lasting complications. Thus, this is why COVID-19 is still considered as a global disease burden. So thus in my research, I have chosen these two respiratory diseases. They are linked with periodontitis through their shared mechanism of inflammation and immune response. So let's see how COVID-19 is related to periodontitis. So COVID-19 caused by SARS-CoV-2 virus highlights an intricate link between the chronic infectious disease and inflammatory conditions. So although it primarily affects the respiratory system, mounting evidence suggests that systemic inflammation and immune dysregulation will also influence the COVID-19 severity, thereby underscoring the role of periodontal disease as a modifiable risk factor. So let's see how basically a virus enters the cell. So the S protein of the SARS-CoV-2, it binds with the ACE2 receptor which is present in the lung cell, and the host protease enzyme cleaves this S protein, and thus the virus enters the cell, and from there the RNA is released, it gets replicated, translated, and a new viral protein is formed which is called viron. which is actually released and then it get infected further. Similarly, in periodontal structure, we have two routes of entry. One is that directly the S protein will bind with the SARS-CoV-2, I mean the ACE2 receptor present in the periodontal structure, and virus is released. But in second route of entry, there is endosomal entry where there is internalization of the virus, and within the endosome, the enzyme will cleave this protein and thus the virus has been released. So let us see how periodontitis influence the COVID-19 severity. So the first hypothesis is actually whenever there is an aspiration of periodontal bacteria, it will upregulate this ACE2 receptor, which lead to entry of SARS-CoV-2 more and more. And second one, apart from the host protease enzyme, periodontal bacteria will also produce the enzyme called protease, which will cleave this S protein, thus making more and more entry of SARS-CoV-2. Second mechanism, both COVID-19 and periodontitis trigger a robust immune inflammatory response, which is called as cytokine storm. So this will lead to organ failure and death. So both periodontitis and COVID-19 share a similar pathway. How when the virulence factor in periodontitis, a virulence factor of this bacteria will actually activate the receptor, and then the cytokine get activated, it has been released. Similarly, in SARS-CoV-2, the S protein and E protein get bind to the membrane, and then the receptor is activated and cytokine is pathway is triggered and cytokine is produced. So another interesting way of how a virus enters is whenever there is poor oral hygiene, what happens, the permeability is increased. So there is direct entry of virus from the venous drainage of the mouth to the jugular veins of the neck to the right side of the heart, then to superior vena cava and directly to the pulmonary vessels. Even after the initial infection of COVID-19, some symptoms appear for even weeks, months or years. Such condition is called as post-COVID-19 or long COVID-19. Such symptoms include dyspnea, fatigue, post-stress traumatic disorder, brain fog. So even periodontitis have a role. In a post-COVID-19 patient, already there is a persistent inflammation and there is immune dysregulation that causes cytokine storm. So in an individual which is who has got existing periodontal disease, in those cases also there will be persistent immune response. So that will amplify the cytokine storm and it will lead to pulmonary edema and death. So thus the relationship between both periodontitis and COVID-19, it reflects a complex interplay of which a biomarker which is of diagnostic and prognostic potential is required. One such biomarker is galectin-3. So galectin-3 is expressed in all the cells like endothelial cells, epithelial cells and immune cells, and it also plays a major role in cell growth, cell proliferation, cell differentiation and inflammation. But why I chose galectin-3 for my study? Because it has got a structure similar to that of S protein of spike protein of the SARS-CoV-2. In what way they are similar? Galectin-3 has got a receptor binding domain. Similarly, the S protein has got two domains. One mentioned earlier, it will bind to the ACE2 receptor and it enters. But the second domain, it mimics to that of the galectin-3 where it actually binds to the carbohydrate recognition domain of the host. So in turn, there is lot of entry of SARS-CoV-2, it facilitates more and more of virus entry. Second one, when there is inflammation, this hyper-responsiveness of all the cells like endothelial cells, macrophages and immune cells, which will actually release the more and more of galectin-3. So when there is elevated galectin-3, this in turn will actually activate the cytokine pathway that will also release more of cytokine, causing cytokine storm syndrome. So not only in COVID-19, galectin-3 also has a role in periodontitis. So how it enhances the microbial adhesion to the epithelial cell, it causes disruption of intercellular junction, it modulates the cytokine release, it enhances the Th17 response, and also it causes hyperactivation of neutrophil, which help us to find out that even for periodontitis, galectin-3 can be used as a biomarker. So moving on to my second disease entity, that is chronic obstructive pulmonary disease. It's a progressive systemic inflammatory disorder of the lung which is characterized by persistent limitation of airflow. It contains both bronchitis, which is actually excessive production of mucin, and emphysema, that is where the alveolar membrane will break down. So both periodontitis and COPD will share similar risk profiles like smoking, environmental pollution, microbial infection and diabetes. Apart from that, they also share similar pathophysiological mechanism. So how? Because both will have a neutrophil derived inflammation where there is oxidative stress, and thus it causes connective tissue destruction both in COPD and in periodontitis. So let us see how periodontal bacteria will influence the respiratory disease. So one is that there is direct aspiration of the bacteria. Whenever there is movement of tongue or cheek, the bacteria which is present in the plaque, it enters the saliva and thus it directly get aspirated. Second one, this periodontal bacteria will alter the respiratory epithelium and it will expose the adhesion receptor for respiratory pathogen to come and adhere. So thus more and more of respiratory pathogen gets adhered to the epithelium. Then third one, it will actually upregulate the mucin gene. That's why there will be overproduction of mucin. Fourth one, they'll have a synergistic effect with the respiratory pathogen. How? Because for the growth of respiratory pathogen, it consumes all the dissolved oxygen, creating an environment which is favorable for the growth of periopathogen. That's an anaerobic environment. So periopathogen in turn will increases the virulence factor of the respiratory pathogen, and both together it invades this lung cell. It will lead to the production of cytokines, and thus it may lead to cell death. So there's one more bacteria called Fusobacterium nucleatum, and it has a property called co-aggregation. So this is also a periobacteria. So both whenever they independently get attacked to the lung cell, only the adhesion is happening. But when both get co-aggregated, it more of invasion of the cells into the lung epithelial cells. It causes the inflammatory cytokine release, and thus there is destruction of tissue. So another shared pathophysiological mechanism between COPD and periodontitis is through their neutrophil derived inflammation. So neutrophil basically kills a pathogen either by phagocytosis or by degranulation or by formation of neutrophil extracellular trap. So what is neutrophil extracellular trap? It's a web-like structure which contains lot of enzymes, granules and histones. So when a pathogen come in contact with neutrophil, what happens? The chromatin, it gets decondensed and the nuclear membrane ruptures. So all the contents get released into the cytoplasm. So it can be beneficial as well. This process is called NETOSIS. This can be beneficial or this can be detrimental. When can it become detrimental? When there is excessive formation of it and when it causes destruction. And it is when it is formed at a wrong site, it becomes detrimental. So since histone release is one of the important steps of NETOSIS, I have chosen cetylated histone 3 as a NETOSIS biomarker for my study. So the managing periodontitis, we can have a basic treatment called scaling and root planing. So what does scaling and root planing does? It reduces the systemic level of inflammatory biomarkers, it eliminates dental plaque, thereby limit the presence of pathogenic microbes. But still there is a research gap which is seen. What is the research gap? Linking periodontitis, both, we have many studies linking periodontitis and respiratory disease, but they are all associative. So there is still lack of strong causal evidence. 2, there is insufficient biomarkers. There is incomplete clarity of NET's regulatory mechanism, and there is very high quality randomized control trial to evaluate the effect of non-surgical periodontal therapy on COPD outcome and exacerbation. So why these gaps matter? Because such studies will enable personalized risk assessment, guide therapeutic intervention and improve outcome for patients with concurrent periodontitis and respiratory disease. So thus, the aim of my research is to investigate the relationship between respiratory disease such as COVID-19 and COPD and periodontitis in relation to pathogen load and biomarkers, while also evaluating the impact of non-surgical periodontal therapy in reducing both respiratory pathogen burden and NETOSIS biomarker level. So what are my objectives? First objective is to analyze and compare the salivary and serum galectin-3 level in COVID positive individuals and COVID positive with and without periodontitis individuals. Then second one, to examine and compare the salivary and serum galectin-3 level in periodontitis without the history of COVID-19 patients and in a post-COVID and periodontitis patient. So the third objective is to assess the prevalence of the respiratory pathogen Pseudomonas aeruginosa in the subgingival plaque of COPD with and without periodontitis patient. Fourth one, to investigate the presence of periopathogen, that is red complex bacteria and Fusobacterium nucleatum again in the lung fluid, that is called as bronchoalveolar lavage fluid, again in patients with COPD and with and without periodontitis. Fifth objective is to assess the salivary level of NETOSIS biomarker cetylated histone 3 again in COPD with and without periodontitis patient. And my sixth objective was to compare the effect of non-surgical periodontal therapy on pulmonary function, salivary scintillated histone 3 levels, and respiratory pathogen burden in patients with periodontitis and those with both COPD and periodontitis. So my research included two prevalent studies. First one is actually association between COVID-19 and periodontitis, which included two case control study. And second one is association between COPD and periodontal disease, which included 3 case control study and one interventional study where included non-surgical periodontal therapy in reducing the pathogen load and NETOSIS biomarker level in periodontitis and COPD with periodontitis patient. So sample size was calculated, then ethical clearance was obtained from the institutional ethical board, and then informed consent was obtained from all the patients. And moving on to my first module, that is association between COVID-19 and periodontitis, which had 2 case control study. First one analyzed salivary and serum galectin 3 level in COVID positive individuals with and without periodontitis, and second one to which compared salivary and serum galectin 3 level post COVID periodontitis patient. So totally 120 patients were enrolled, out of which 4 were absent for the study and 2 declined to participate. So healthy controls, group 1 had 25 healthy control, group 2 25 periodontitis patient, group 3 23 COVID-19 patient, group 4 22 COVID-19 plus periodontitis patient, and group 5 post COVID-19 plus periodontitis patients. So all the patient respiratory patients, I mean COVID patients, were obtained from Lalithambika Medical College and Hospital during the period from Jan 22 to December 2023. So once they turned RT-PCR negative, after taking a willingness to take part in the study, they were scheduled for periodontal examination. So group 1 included healthy patients where there was no visual signs of gingival inflammation, no clinical attachment loss, and their serological test for anti-SARS-CoV-2 was negative. And group 2 also included periodontitis patient, and they also had serological test was negative. Group 3 included RT positive, PCR positive patient, but periodontally healthy. Group 4 included RT positive patient and with periodontitis. Post-COVID included moderate to severe COVID-19 cases who had moderate to severe COVID-19 cases, that is their oxygen saturation was less than 94 and they were hospitalized. Such patients were included in post-COVID group and they also had periodontitis. So a patient with active disease like diabetes, hypertension, or current or former smoker, pregnant ladies and lactating mother, and individuals who were subjected to any therapy for periodontal disease for a period of 5 to 6 months were all excluded from the study. So saliva and serum samples were collected to estimate the galectin 3 level using ELISA kit. These are the components of kit. So we have a microtiter plate which is pre-coated with the antibody for galectin 3, into which the samples were added, substrate were added, and we can see the color change. So this color change was, intensity of this color was measured using ELISA reader. So moving on to my results. So we can see the periodontal parameters, that is PPD, CAL, GI and plaque index. All this was statistically significant among the groups. But you can see in COVID positive plus periodontitis patient, that is group 4 patient, they had higher PPD and CAL. This shows that the periodontal destruction was more in that group, that is in COVID plus periodontitis group. And also plaque index and gingival index was also higher, shows that they had poor oral hygiene with increased plaque accumulation and increased gingival bleeding. So this shows that increased periodontal inflammation will worsen the COVID-19 outcomes. One is that because there is aspiration of the periodontal bacteria, which would have enhanced the ACE2 expression and would have promoted more and more of viral entry. And second one, combined systemic inflammation intensified this COVID-19 cytokine storm in individuals with pre-existing periodontal disease. So we can also see that serum, both serum and salivary galectin 3 level was seen higher in the group 4 patients than in periodontitis patient, followed by COVID-19 patients, and it was least in healthy patients. So this shows that galectin 3 is a dual biomarker and a potential therapeutic target linking periodontal inflammation and COVID-19 due to the enhanced viral attachment. As I mentioned earlier, this is due to the structural similarity of the galectin 3 with the spike protein of the SARS-CoV-2. It would have facilitated more and more of virus. And also second thing, amplification of cytokine response, thereby contributing to worse COVID-19 outcomes. And moving on to my second study result, so we can see the post COVID-19 plus periodontitis patient, that is group 5, had higher PPD, Cal, GI and plaque index. This is because the long lasting inflammation in a post COVID patient would have had persistent cytokine activity that would have actually exacerbated the periodontal destruction. And in patient in pre-existing periodontitis patient in turn would have intensified this long COVID related systemic inflammation. And also the mean salivary and serum galectin-3 level was also seen higher in post-COVID and periodontitis patient. So this shows that galectin-3 links long COVID inflammation with periodontal destruction. And also it showed a positive correlation with all the periodontal parameters, showing that higher plaque accumulation, deeper pocket and clinical attachment was all seen elevated with elevated galectin-3. So thus it can be a marker for disease progression. And my research was the first to evaluate the periodontal status and salivary and serum galectin-3 both in active and in recovered COVID-19 patient, supporting galectin-3 as credible biomarker for severity of both periodontal disease and COVID-19 infection. So moving on to my second module, that is COPD and periodontal disease, where 3 case control studies were involved. One was to evaluate the respiratory pathogen in subgingival plaque, okay, and second one to evaluate the periodontal pathogen in lung fluid, that is the bronchoalveolar lavage fluid, and third one is to evaluate the NETOSIS biomarker citrulated histone 3, again in saliva of periodontitis and COPD with and without periodontitis patient. Then one interventional study which explored the effect of non-surgical periodontal therapy in reducing pathogen load and NETOSIS biomarker level in individuals with periodontitis and those with both COPD and periodontitis. So for evaluation of respiratory pathogen and for the evaluation of citrulated histone 3, I had 4 groups. So group 1 had 20 subjects, that is periodontally and systemically healthy. Group 2 had systemically healthy but they had periodontitis. Group 3 had COPD patients but with healthy periodontium, and group 4 had both COPD and periodontitis. And for my next study, where periodontal pathogen was evaluated in lung fluid, only 2 groups were involved, that is group 3 and group 4. Again, all the COPD patients were taken from Lalithambike Medical College and Hospital, and all the periodontitis patients were taken from the OP department of our Thaimoogambigai Dental College. So we can see that group 1 had healthy patients with no signs of gingival inflammation and no clinical attachment loss, and systemically also they were healthy. And group 2 included periodontitis patients but they were systemically healthy. Group 3 had moderate to severe COPD cases where their forced expiratory volume in 1 second was between 50 to 70 only, and their forced vital capacity was less than 0.70, okay, and they had healthy periodontium. Group 4 had both moderate and severe COPD cases but with periodontitis. And any patients with aggravation of respiratory symptom with last 6 months, pneumonectomy, patient who had undergone any pneumonectomy or lung transplantation surgery, or patient who has taken any periodontal management in the past 6 months were all excluded from the study. So both subgingival plaque and saliva was collected. So subgingival plaque was collected by using a curette from the mesial side of the molar, and that is collected to evaluate respiratory pathogen. And saliva, the patient were asked to spit the saliva, and that was collected to evaluate the citrulated histone 3. Again, BALF, that is lung fluid, was collected to evaluate the periodontal pathogen. Both the periodontal pathogen and respiratory pathogen was evaluated using real-time PCR, and the salivary histone level was evaluated using ELISA kit. So we will see how a that is BALF, that is bronchoalveolar lavage fluid, was collected. It was done by using bronchoscopy. So we can see a long flexible fibro-optic bronchoscope which has got a mini camera on one end, and the other end was attached to the videoscope. So under anesthesia, this long flexible bronchoscope was entered nasally, and then it was advanced to the bronchopulmonary segment until it occludes the bronchus. Then around 3 to 5 aliquots of this phosphate saline was instilled, and in minus 40 to 50 negative pressure, the fluid was aspirated back. Around 5 to 10 ml was aspirated back. This is the lavage fluid, and this was actually collected and it was placed into the falcon tube or the tube which is used for evaluation. So I have put a video where you can see this. See, this is the long flexible bronchoscope and it is inserted nasally into the I think it's small, and then it is advanced until it reaches the bronchus. I think it's the video stuff. Then you can see that the saline is being instilled, around 3 to 5 liquids of saline was instilled, that is around 50 to 100 ml was instilled, and with negative pressure around 5 to 10 ml was aspirated back. That was then transferred to the falcon tube. So both the samples were from both the samples DNA extraction was done using DNA extraction kit. So then it was centrifuged first, then a digestion buffer was added to it, it was incubated, then again it was centrifuged, and the purity of the DNA was checked using nanodrop. So after the extracted DNA along with the primers specific for the pathogen were all mixed together, and then it was microcentrifuged. Then it was each tube was placed in the PCR machine to amplify the DNA product using various temperature cycles, and then gel electrophoresis was done to visualize the DNA banks, and this plate was then placed in the electrophotogram where you can see the presence of pathogen. So now the quantification of this pathogen was done using real-time PCR where a standard curve was plotted, and this amplification of this pathogen was evaluated using cyclic threshold values or CT values. So circulated histone 3 was evaluated using the ELISA kit. So the microtiter plate which was pre-coated with the antibody for circulated histone 3, into that the solution was added, the samples were added and the substrate was added. We can see the color change, and this intensity of the color was measured using ELISA reader. So moving on to my results. So we can see that all lung functional parameters and periodontal parameters, that is PPD, CAL, GI and plaque index, all this was actually statistically significant, with group 4 having the highest parameters, but lung functional parameter was lowest in both group 4 and group 3 and group 4. So we can see lower the CT value indicates higher the pathogen load. So we can see COPD and periodontitis, and in periodontitis patient had lower CT value, which indicated they had higher pathogen load, that is higher respiratory pathogen load. So this showed that higher pathogen load, it was also correlated with all the periodontal parameters. So as the pathogen load increased, all the parameters increased, but there was reduction in lung functional parameters. So this is because of pure mucociliary clearance in the COPD patient. Thus there is direct microaspiration of the oral secretion, and also dental plaque, it acted as a secondary reservoir for the respiratory pathogen to adhere. And not only that, periodontal bacteria would have actually altered the respiratory epithelium and would have exposed the receptors favorable for the respiratory pathogen to adhere. And we can see a moderate correlation with the periodontal parameters and lung functional parameters. So as the periodontal parameters increased, there was reduction in lung function parameters. So for evaluation of periodontal pathogen, my fourth study, again we can see lower CT values of all the pathogen in COPD with periodontitis, showing that they had the higher pathogen load. And again it was all correlated with the periodontal parameters. So as the periodontal parameters increased, the pathogen load increased, the periodontal parameters also increased, but there was reduction in lung functional parameters. So why it could be because as one could be the direct aspiration of these bacteria. Second one, after aspirating, they would have actually upregulated the mucin production, and then there would have been excessive mucin production. And one second thing was actually that it would have had a synergistic effect with that of respiratory pathogen. As I mentioned earlier, the growth of respiratory pathogen will consume all the dissolved oxygen, and it will create an environment which is favorable for the periopathogen to grow there. Okay, and then one more thing, in my study, I could see even Fusobacterium nucleatum was also elevated in group 4 with periodontitis patient. That it would have caused co-aggregation with the respiratory pathogen, and thus would have caused more of destruction. So this could be the reason of lung functional decline more in my group 4 patient, that is in COPD with periodontitis patient. And my study was the first to utilize the valve, that is lung fluid, for analysis. So we can see the NETOSIS, in my fourth study was the evaluation of NETOSIS marker, that is circulated histone 3. So it was seen elevated both in periodontitis group and COPD with periodontitis group. So it was positively correlated with all the periodontal parameters. So as the marker increased, all the periodontal parameters also increased, and the lung functional parameter was decreased. So this is because hyperresponsiveness of neutrophil would have caused more and more of net release. So once the net release is there, histones would have been released more. So that's why my marker was increased in that case. Moving on to my last study, where we have done non-surgical periodontal therapy, and you can see a significant reduction in PPD, CAL, gingival index and plaque index for both periodontitis and COPD with periodontitis group. And also there was a reduction in NETOSIS biomarker, that is circulated histone 3, and you can see the higher the CT value is improved. So that means there is reduction in pathogen load. And also lung functional parameters significantly improved in group 4, that is in COPD with periodontitis patient. So this indicates that the SRP would have disrupted the synergistic effect with that of respiratory pathogen, and would have also reduced the microbial translocation to the lungs. So that is one reason. Second one, decreased periodontal inflammation would have reduced the systemic net formation, and thus the respiratory functions would have been improved. So this is more emphasized by doing the linear regression analysis. So in this showed a significant negative impact of periopathogen on lung functional parameter, which indicated that each unit increase in periopathogen led to the decrease in lung functional parameters. Same way, each increase of the respiratory pathogen led to the increase of all the periodontal parameters, but reduction in lung functional parameters. Thus, my research found, first one, there is a strong biological plausibility linking both COVID-19 and COPD with periodontitis patient. Second one, galectin-3 acts as a dual biomarker for both periodontal disease activity, COVID-19 and post-COVID-19 severity. Yes, definitely there is a oral pulmonary axis. One, as the periodontal parameters increased, all the pulmonary functions decreased, and respiratory pathogen reflects the poor oral health, where we could find that dental plaque, it acted as a reservoir for the respiratory pathogen to adhere. And our study was the first to do the BALF. So in that we could see that there was a direct microbial translocation of the periopathogen to lung. So thus this periopathogen can be a valuable diagnostic marker for identifying individuals at risk for exacerbation. And non-surgical, fourth one actually, NETOSIS, that is a newer mechanism for neutrophils, that is also shown as a shared inflammatory mechanism with both COPD and periodontitis, with elevated circulated histone 3 reflecting acute inflammatory burden and NETOSIS activation. And also non-surgical periodontal therapy reduced the inflammation and pathogen load, thus periodontitis is a modifiable risk factor. It also improved the lung function in COPD patients. So thus periodontal therapy supports the respiratory health. So to conclude, periodontitis and respiratory disease share inflammatory and microbial pathway, with galectin-3 emerging as a key biomarker linking COVID-19 severity, post-COVID complication and periodontal inflammation. Second one, the presence of periodontal pathogen in the lungs and presence of respiratory pathogen in the oral cavity with elevated NETOSIS marker in COPD patients with periodontitis highlighted a strong oral pulmonary connection. Then non-surgical periodontal therapy, it reduces the pathogen load, inflammation and improves the lung function, underscoring the importance of periodontal care in respiratory disease management. So I would recommend to the public that we are all still living in the era of COVID-19. So thus maintaining a healthy gums and treating periodontitis will definitely reduce the post-COVID complication. And just by doing a regular, very accessible period treatment, that is non-surgical periodontal therapy. And so we dentists, especially periodontists, play a significant role in preventing respiratory disease by redoubling their effort to prevent periodontitis and to arrest its progression. So these are my references. My work got published in both national and international journals. So I thank, my sincere thanks to all the management team, that is Founder Chancellor Thiru A.C.S. Shanmugam sir, President A.C.S. Arun Kumar sir, Secretary Thiru A. Ravi Kumar sir, Vice Chancellor Dr. S. Geeta Lakshmi Madam, Registrar Dr. C.B. Palnivelu sir, and I also extend my sincere gratitude to Dr. A. Tirunavukarasu sir, Senior Director, Dr. S. Ramamurthy, Director, Dr. S. Bhaskar sir, Dean Research, Dr. Rajeshwari Hari, Additional Dean, and to entire research department team who helped me from the beginning till the end. And my deep gratitude to my beloved guide, Dr. Uma ma'am. Thanks ma'am, she was actually not only my guide but my mentor right from my postgraduate days. Thank you ma'am for always being there with me, for supporting me, for always constantly encouraging and motivating me, and also for a patient guidance ma'am throughout this research. Thank you ma'am. And thanks to Dr. Vijayalakshmi ma'am, who was my external expert. Ma'am with her friendly nature and her encouraging words always supported me. Thanks to Dr. Shankaram sir for always supporting me. Heartfelt thanks to Dr. Snowfia ma'am with her most friendly nature, with comforting words and kindness. Ma'am was always there to support me. And thanks to Dr. Lalita ma'am, she always motivated me as my PhD batchmate. Literally, she pushed me in every step, and thus to keep going in all the way. Then thanks to Dr. Gopal sir and Dr. Manoj sir for all constantly encouraging and supporting me. Thanks to Dr. Datri, who always actually motivated just by saying that just 2 more steps ma'am, just 1 more step, we'll just finish up, this is the last one. Thank you Datri. Thanks to special thanks and gratitude to Dr. Navina, my friend, who has always been my steady support from the beginning and has helped me throughout from the beginning till the end. And also to Dr. Archana and Dr. Catherine, they have actually helped me whenever I needed the help, they helped me. And all my postgraduates who has helped me throughout, and all the non-teaching staff, especially Menaka sister, who helped me to take all the printouts for the day. And I also extend thanks to Dr. Shanmugapriya. Ma'am could not come today. She is the associate professor from respiratory medicine. She was the person who helped me to take all the respiratory sample with full dedications. So I really thank her. Then also I thank the Savita Blue lab and biochemistry lab to do all the analysis for the sample, and also Dr. Keshavan sir, who did all my statistical work. And I also thank my international examiner, Dr. Ramesh Babu. He has come all the way from Andhra, and he is accepted to evaluate my research. Thank you, sir. And also my international examiner, Dr. Kameshri, who is from MST University, Malaysia. And also I extend my deep gratitude to my family. My father, Mr. Mithradas, and my mother, Mrs. Sushama Mithradas, who are the true reason why I am standing here before you. And their sacrifices, their blessings and their support was always there for me throughout. And I am sure that my dad would be the most happiest person for me today. And unfortunately they could not come today here. And I also thank my sister Mrs. Nishita and my mother-in-law Mrs. Geeta Rajendran, who always supported and encouraged me. And also I take this opportunity to actually extend my gratitude to my husband Rajesh Rajendran, who actually was my pillar of support. And he always, he supported and motivated me throughout to overcome all the challenges which I face day to day during this research journey. And I also appreciate my son Adidev Rajesh, who is also, whatever sacrifices and understanding which he has done throughout the research is also appreciable. Then all my friends, I thank all my friends who have come today, Prasanna, Nisha, then Suresh sir, Vasudevan sir, who has spent their valuable time to support me today. And I thank everyone. I thank even Nadeem sir, who has come today, Gayatri ma'am from Ortho, Rajkumar sir, and Suganya ma'am, Sheila. I thank each and everyone who has come today to help me out today. And my humble and heartfelt gratitude to God the Almighty, who has always showered the blessings to me. Thank you. Thank you one and all.
It's a very good presentation, Nimisha. It's a very good scientific research topic selected. A very good data interpretation and also clinical relevance is very good interdisciplinary study. Those are very good informative. Just I would like to some points to clarify from you. First and foremost, based on your results, what's the influence on health profile, public health policies, or any interdisciplinary between periodontal and pulmonary collaborate?
One main thing actually, my results demonstrated that periodontitis actually increases the respiratory burden. by increasing the pathogen load and by increasing the pulmonary, reducing the pulmonary function. And my study also showed that periodontal therapy actually reduces the pathogen load and increase the pulmonary function. So thus, regular periodontal screening as a part of the all the respiratory disease programs can be will be done, and we can promote both the the pulmonologist and periodontist to join together and inform the public regarding the importance of the periodontal screening in initial phases itself.
Okay.
So that can be always a part of the respiratory disease programs.
There is a global significance in studying such studies such as association with periodontitis and some systemic diseases such COPD and COVID-19.
One is actually this strong link is very globally important, as periodontitis actually is linking, that itself is the most prevalent disease in the world, and also we have seen that COPD, it is the third leading cause of death and around 3 million people die every year. So such cases actually this is very important, where during initial phases you can find out actually whether that patient has, the person has got a periodontal disease. So you can prevent the exacerbation of such disease by just doing a normal scaling and root planing, most accessible treatment. So we can actually inform the public regarding it. You can always include this as as one of the adjunct to the respiratory management program, rather than just using it as a dental intervention program. You can actually add this also to the respiratory disease management programs.
Okay. How does this poor oral health can contribute to the colonization of respiratory pathogens?
So whenever there is poor oral hygiene, we know that the periodontal bacteria, one, it will get directly aspirated. Second one, it will actually alter the respiratory epithelium, and then it will expose the adhesion for all the respiratory pathogen to come and get adhered to it, and that will and also the salivary pellicle, which is around the respiratory pathogen, that is also destroyed by the periodontal bacteria. So thus the more and more of respiratory pathogen get adhered to the epithelium, and that will lead to the exacerbation of the disease.
Congratulations, Dr. Nimisha, for the completion of your research work, and it is very extensive. And here the COVID cases are coming down. How did you manage to collect this?
My sample I was collected actually during Jan 22 to December 23, ma'am. So that was the period which when I collected it. And post COVID, actually still there are people with symptoms which which extended even from weeks, months and years. So like dyspnea, cough, and it also include many systemic diseases also, like cardiovascular sequelae, where there is actually myocarditis, then pulmonary fibrosis, then renal dysfunction, and all cognitive disturbance, like you have a brain fog, then post-stress traumatic disorder. All this can lead to the COVID complications.
You mentioned about long COVID, no? Yes. What is the difference?
Yes, ma'am. After the initial infection of COVID-19, still many symptoms may appear, which will last for more than weeks or months and years. Such condition is called long COVID and post-COVID. So periodontitis also had a role there. So in a post-COVID patient, there was persistent inflammation and there was immune dysregulation. So that will cause cytokine storm. In a patient who already had a pre-existing disease, periodontal disease, there was persistent immune response, which will altogether lead to the cytokine storm, and it would have caused destruction of the tissue.
So what is the importance of selecting these two markers, galectin and NEXUS?
One thing actually we can see, it was elevated both in periodontitis as well as in COVID-19 patients. So one important thing why I chose galectin 3 was that it had a structure which is similar to that of COVID-19. So you can use galectin 3 inhibitors where it can disrupt the domain action there, and also you can reduce the cytokine storm which is caused by galectin 3. And my cetylated histone 3, that was one of the most important step in NETOSIS formation. So whenever the histones is released, that can be evaluated by using this biomarker, that is cetylated histone 3.
Any phytochemicals can be used to inhibit these markers?
Yes, ma'am. Actually, my future thing is actually I am planning to do tulasi, that is a herbal plant which is readily acceptable, and that already has a property of antioxidant, anti-inflammatory, and antimicrobial effect. So which would have I'll be using it as an adjunct to the SRP, that is scaling and root planing. So it has got effect both in periodontitis and in COPD with periodontitis, and also it has got essential oil which will act as a bronchodilator for this such COPD patients. So we can actually combine I'll formulate it later.
Thank you. All the best.
Any questions from the audience? Open to questions.
Very good presentation, Nimisha. Biomarkers we have which are close to periodontitis.
There are a lot of biomarkers, sir. Lot of biomarkers are there. Yes. In my thing actually about it is related to COVID-19. I was the first to find out galectin-3, which is present in both in COVID-19 and periodontitis. So that is one of the new markers. And NETOSIS, that is scintillated histone 3 also. I've recently seen that it is seen in COPD with periodontitis patients. It is aggravated both in periodontitis and COPD patients.
Presentation, Nimisha.
Thank you, sir.
Your study is very nice, showing the strong association between respiratory disease and
Yes, sir.
Just I want to know what is the role of this periopathogen in the aggravation of respiratory?
Yes, sir. It has got a very important role. That's why actually can be considered as a diagnostic tool for initial respiratory disease burden. So one thing is that whenever there is the aspiration of this periobacteria, it will actually upregulate this mucin gene, and thus there is overproduction of mucin. One thing. Second thing, actually it will have a synergistic effect with that of respiratory pathogen. See, as respiratory pathogen grows, it will consume all the oxygen, and it will create an environment which is favorable for the respiratory pathogen to come. So both together it will invade the lung cell, it will actually cause destruction of the cell. And also one more important bacteria is Fusobacterium nucleatum, which has got a property of co-aggregation. So both together it will actually co-aggregate, it invades the lung cell, and that will also cause destruction. So that's why periodontal bacteria can act as a valuable diagnostic tool for actually evaluation of respiratory disease.
You mentioned that DNA extraction kit, no?
Yes.
What was the cost? Helsinki.
Yes, sir. Actually I did in Savita lab. So altogether they charged actually. So first DNA extraction was done. Then into that the primers were added, and I did a PCR, and whichever pathogen was seen, I had quantified that using real-time PCR. So each sample costed around 800, 900. So that's why I limited my pathogens. Otherwise, I would have done more of respiratory pathogens, and in future I may do genome sequencing, so that apart from this bacteria, I can see all the other bacteria which will cause the aggravation for this respiratory disease.
That you have to do, right? Then what about that anti-SARS-CoV-2 kit?
Yes, sir. Yes, sir. That actually my husband is working in Roche Diagnostics. So that kit is actually ELIX SARS-CoV-2 kit. So if you are already, if you had the COVID-19, the antibody would be released. So that you can actually identify using that kit. So this my group 1 and group 3, group 2 I excluded by using that kit. It was negative, the anti-SARS-CoV-2 was negative for those patients. So that means those patients never had COVID-19. If they would have had, that antibody would have been released, and that would have shown as positive in this. And we have some range there, around 0.2, 0.8 milliliter presence of that antibody.
Presentation.
Okay, very good presentation. As you defended everything, there's some queries and questions raised by whoever is present here. So I would highly recommend you to an award of Ph.D. from Dr. M.G.R. University.
I thank you all for joining. In the beginning, I went into the topic, so I just want to share a few words about Nimisha. She is one of the my best student, and I can say she is also a family friend of mine. But even though she never takes advantage, she knows she can get the things done. But she's to the core. She did everything by herself, and she went and collected all the samples, and it went as she had planned. And I would really suggest, my PG students are here, I just want them to take her as an example. She puts in her maximum effort and she gets the best of it, and one of the best good human being. And thank you all for joining us, Nadeem, Hari, and Vijay from Addl, all our family people who are supporting her throughout. And special thanks to Rajesh. I think last 4 years he has really like contributed so much. And thank you, Ramalingam sir, for joining. So, நீங்க உட்காந்து கேட்டதே எங்களுக்கு பெரிய விஷயம் சார். Thank you so much. உங்களோட blessingsனால தான் எல்லாமே நடக்கும் சார். Thank you. And from all the faculties, from Sheila, Rajkumar, Suganya, everyone, thank you so much for joining us today.